Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Medical errors are the third leading cause of death in America, but mistakes often go unreported. Can we fix what we don't measure? This is the People's Pharmacy with Terry and Joe Graydon.
Even insiders who suffer medical mistakes themselves can have a hard time learning what went wrong. Today we're talking with the patient in room 2. It's a nurse's story of surviving preventable errors and discovering the truth.
What can you do to protect yourself and those you love against common medical mistakes? What questions should you ask before agreeing to surgery or another medical procedure? How realistic is informed consent?
Coming up on the People's Pharmacy, Donna Helen Crisp gives us an anatomy of medical errors.
First, this news.
In the People's Pharmacy Health Headlines, vitamin E and selenium do not appear to be helpful in preventing dementia. Over the last several decades, neurologists have considered oxidative stress as an important risk factor for neurodegenerative disorders like Alzheimer's disease. That's why they hoped antioxidant supplements might protect older people from cognitive decline. But a new study in JAMA Neurology shows no benefit from either vitamin E or selenium or the combination. The study ran from 2009 to 2015 and included 3,786 older men. They were randomly assigned to get vitamin E, selenium, a placebo, or a combination of the two antioxidants. They were tested for cognitive impairment. An equal proportion of men in each group developed dementia. The authors concluded that the supplements were no better than placebo.
Medications to shrink an enlarged prostate may contribute to depression. Drugs like dutasteride and finasteride are prescribed for benign prostate hypertrophy, or BPH for short. These medicines prevent the conversion of testosterone to dihydrotestosterone. It is this metabolite of testosterone that causes prostate tissue overgrowth and male pattern baldness. Lower levels of dihydrotestosterone have been linked with fewer symptoms of BPH, such as urinary frequency or nighttime urination. Neurologists have become concerned that these medications do not just affect the prostate or the scalp. Reports to the FDA have raised alarms about suicide. An epidemiological study of over 90,000 older Canadian men found no increased risk of suicide among men taking either finasteride or dutasteride. There was, however, an increase in depression, and such men were more likely to harm themselves. The absolute risk was low, but men and their partners should be informed of this possibility.
Scientists have long wondered how acupuncture works. Now, an international research team with more than 40 members has evidence that a neurological mechanism may be at work. In the earliest studies, the test subjects were horses. Then the investigators turned to rodents and people to clarify the effects of electroacupuncture. The stimulus reaches the brain, which in turn releases stem cells that can repair damage. Electroacupuncture stimulation at certain specific points triggered parts of the brain that are involved with the immune system as well as the nervous system. The electroacupuncture treatment also raised the subject's pain threshold and increased their production of tendon-repairing collagen. The investigators anticipate that understanding the effects of electroacupuncture in this way will facilitate its use in both human and veterinary medicine.
A new high-tech treatment for migraines utilizes mild electrical stimulation controlled by a cell phone. Investigators studied people who averaged 2 to 8 migraines a month. A special patch containing electrodes, a computer chip, and a small battery was applied to the upper arm. The devices were programmed to deliver either placebo stimulation or active electrical pulses. When patients activated the device with their phones, pain was reduced by almost half.
A Canadian study suggests that not everyone who has been diagnosed with hypertension actually has the condition. In fact, perhaps 1 in 5 has been misdiagnosed and is taking unnecessary medicine to lower blood pressure. That's because measuring blood pressure is trickier than it looks. The technology for determining blood pressure has improved quite a lot over the last few decades, and machines can be very accurate if they're used properly. But a survey of Canadian family physicians found that more than half of them still measure blood pressure manually, even when the clinic has a machine. To do a good job taking blood pressure, you need about 15 minutes for the patient to be sitting quietly and having several measurements made. But a single manual reading takes a lot less time. Ambulatory 24-hour blood pressure measurement is the gold standard for diagnosing hypertension. Accurate measurement of blood pressure is critical to controlling high blood pressure. That, in turn, can reduce the risk of stroke, heart attack, and kidney problems. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Ever since 1999, when the Institute of Medicine issued its report, "To Err is Human," the medical profession has been alerted to the problem of medical errors. Healthcare harm may contribute to nearly as many deaths each year as cancer or heart disease. Adverse drug reactions, misdiagnoses, hospital-associated infections, and treatment mistakes all take a tremendous toll.
How would you even know a mistake had occurred? The CDC keeps no statistics on iatrogenic deaths. We have a National Cancer Institute, a National Heart, Lung, and Blood Institute, and many other institutes within the NIH. Billions are spent to study diseases. But there is no National Institute for the Prevention of Medical Errors, and very little funding is available to study this problem. That's why today we're talking with Donna Helen Crisp, author of Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth.
Donna Helen Crisp was a nursing professor on the morning she was admitted to a hospital for surgery. Instead of going home the next day, she suffered multiple medical errors and spent a month in the hospital, much of it in a coma. When the hospital refused to comment, Crisp spent 8 years researching and writing her book. She's here today to talk about what she learned. Welcome to the People's Pharmacy, Donna Helen Crisp.
Good to be here.
Donna Helen, please tell us your story. What happened?
I went into the hospital on a weekday summer morning. I remember giving my insurance cards to the clerk. A friend had driven me. We went back to a room where I was to change clothes, which I did, and wait for the surgery. An anesthesiologist came in, and I don't remember what he asked me, but the next thing I remember is almost a month later, 3 weeks later, as I'm coming out of a coma. I'm psychotic for a while, but I'm aware of being alive. And I learned almost immediately that something had gone wrong. I wasn't sure what, but what had happened was when I had a diagnosis of uterine cancer, and I'd gone in to have a laparoscopic hysterectomy. And when they harvested lymph nodes before they took out my uterus, they used these graspers called non-traumatic, ironically, graspers, which they had 2 of them pulling back my small intestine. And unbeknownst to them, they had ratcheted these graspers down with too much pressure, about 4 or 5 inches apart. And the surgery ended, and they didn't know anything had gone wrong. But what had happened was, where each grasper was, there was bruising, which later developed into hematomas. And then early the next morning, when I started experiencing excruciating pain, those hematomas, we all suppose, burst open. And that was the beginning of a long series of activities to save my life.
Having your intestines open is a terrible, terrible thing. But even worse, they didn't realize it right away, right?
That's right. That was actually the worst thing. They wrote orders for me to be discharged the next morning, and I'd been writhing in pain all night. I have no memory of this. But they said I could have scrambled eggs and coffee, and they actually wrote the discharge orders. There were 8 or 9 residents working where I was. They had no one to oversee what they were doing, which I didn't know this for 2 years. And they just assumed that the carbon dioxide gas, which is typically used to open up the space before you do a surgery laparoscopically, that the remainder of that gas was causing pain. So they didn't even think about the worst complication of such a surgery, which is probably perforation.
So let's explain for our listeners, because not everybody understands the difference between laparoscopic surgery and open surgery, what it was they actually did, and then what were the consequences when the intestines opened up.
Well, laparoscopic surgery is where instead of a long incision, they put tiny little holes into the area. Gallbladder surgery is often done this way as well, and other surgeries. They have several tiny holes. One is for the camera, and 1 or 2, I'm not sure how many holes I had. I think I had 3. I had at least 3 because the grasper was inserted through 2 graspers, 1 through each hole, so that's 3 holes. And so they're manipulating these instruments by looking at a camera that's inside my body. Now they use robots to do this more often than they did back when I had this surgery. So the good thing about this kind of surgery is that there's a less time for recovery. I was expecting to go back to work the next week. In fact, that was a huge asset to me, that I would be able to go back to work and not miss more than a week. If I had known that there are lots of problems at times with this kind of surgery, I would have chosen the regular incision. But none of this was explained to me in the pre-op about the risks or benefits of each. My doctor recommended this, and I said that sounded good.
Now, you're an insider. You're a nurse. You, in theory, should have been told immediately when things started going south, A, oops, there was a problem. B, this is what we're going to do to fix the problem. But in a sense, you were kept in the dark, as if you were like any quote-unquote normal patient.
Well, I was awake and alert the night that the pain started and all the next day when they weren't doing anything to find out what was wrong.
What did go wrong?
The doctors didn't find out that I had a perforation until late the second day. They didn't do a CT scan until a day and a half after I had the surgery. And then when I went to the repair surgery, things got worse. But to answer your question about being an insider, my family knew that something had gone wrong, but I don't think they knew the details. And they certainly didn't know what went wrong in the second surgery.
What did go wrong in the second surgery?
A student anesthetist, nurse anesthetist, was allowed to perform the intubation, and he did it incorrectly. And so I'd had all this barium dye, a few hours before when they finally figured out that I was, filling up with toxins spilling from my bowel. Apparently he didn't know that, and they let him do this intubation, and when he did it the way he did it, all this dye flooded into my lungs, which caused a lot of problems, including chemical burns, pneumonia, and acute respiratory distress syndrome. Also, they didn't realize this had happened. They only half an hour in did they say, oh, the pH level doesn't look right. And they really didn't know the full gamut of what had gone wrong until upwards of a week later.
When did you finally realize that there were these series of medical errors and the degree of harm that took place?
I don't think I understood about the intubation for at least a year. You know, you can't ask a question if you don't know what to ask. And my surgeon told me very little. My sisters, who were there frequently, they knew that things were not right. He had told them that I had aspirated, but they didn't realize why I had aspirated. And then the subsequent 3 surgeries I had were because of raging infection. They had to keep taking me back. I was septic. I had lots of different bacterial infections. And so that's why I had a total of 5 surgeries. I was so sick that just existing in the moment was all I could do, although I knew I would figure it out. And I knew I would write a book from the first weekend I woke up in the ICU, even though I didn't know what it would say. I knew something important had happened.
Can you tell us a little bit about how you went about discovering all these errors? Because, as you point out, nobody came to you and said, well, we're really sorry, but we messed up here.
As soon as I was conscious, I knew I was in trouble. I couldn't move. And before I left the ICU, I was relentless in my trying to communicate that I needed to go home. Oh, I couldn't talk, though. There were tubes down my throat. By the time I was moved out of the ICU, I could talk. I was in another part of the hospital, and I knew something terrible had happened. I just didn't know what. I couldn't wrap my mind around it. And when I realized I'd lost almost a month of my life to a coma, it just felt very bizarre. So I didn't start out knowing specifics until weeks later, even months. But I knew from the beginning something terrible had gone wrong and that I was going to find out if it was the last thing I did.
You're listening to Donna Helen Crisp, author of Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth. Donna Helen Crisp had experience in social work, law, and music before she earned 2 nursing degrees. She has worked as a nursing clinician, an administrator, supervisor, consultant, researcher, and teacher. She's an assistant professor at the School of Nursing of the University of North Carolina at Chapel Hill.
And Terry, you know, most hospitals have a policy of telling people if something goes wrong, but it's not always implemented.
Well, it can be very hard for doctors or other healthcare professionals to admit that they have made a mistake.
After the break, we'll discuss how Donna Helen Crisp finally was able to find out what had happened to her.
Did she ever get an apology from the doctor or the hospital?
What should you know about informed consent? How can you make sure you're truly informed?
How common are medical errors?
There's no institute for medical errors like there is for other conditions, diabetes, heart disease, mental health. How can we get a handle on medical mistakes and make healthcare safer?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339, online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2334. This is show number 1074. That number again, 800-732-2334, or you can place the order online at peoplespharmacy.com.
Today on the People's Pharmacy, our topic is medical mistakes. There's no official reporting system for errors. Consequently, it can be hard to determine how many patients are harmed because of misdiagnoses, preventable adverse drug reactions, or surgical mishaps. An article in the BMJ, formerly the British Medical Journal, concluded that medical errors are the third leading cause of death in the United States. The physician who co-authored that report is a surgeon at Johns Hopkins University School of Medicine. He noted that death certificates rarely indicate if error contributed to the demise of the patient.
A patient doesn't have to die, though, to be seriously affected by a medical error. To find out more, we turn to today's guest. Donna Helen Crisp is author of Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth. She had experience in social work, law, and music before she earned 2 nursing degrees. She's worked as a nursing clinician, administrator, supervisor, consultant, researcher, and teacher. Donna Helen Crisp is an assistant professor at the School of Nursing of the University of North Carolina at Chapel Hill.
Donna Helen Crisp, you had a hard time finding out what happened. It took how long till you finally got the full story?
I would say 2 years. Throughout the 2 years, I was learning things, but I didn't even know to think about or ask about the intubation and aspiration until the year after I was in the hospital.
Did you ever get an apology?
Oh, no. No, I remember once I got out of the ICU and I was in another part of the hospital. I am eternally idealistic, I guess. I was just sure someone was going to come tell me. And I thought, well, of course they haven't told me yet. I was in a coma. They must know I'm not there anymore. I can't move, but I can think, I can pay attention, and I know where I am and who I am. So I was in this room where there were curtains between the door to the hallway and then when you entered into where my bed was. So when the door opened, there was a swoosh. And I sort of perked my head up, and I thought, oh, maybe this is a risk manager or an attorney or a CEO's representative, or someone's going to come tell me, and no one ever came. And so then after I got home, I saw my surgeon, first of all, a couple of times a week. I had to go in a wheelchair. And I couldn't ask many questions. He was very, very friendly, but always in a hurry, and he never really answered my question. At first, I didn't even know he hadn't answered it yet. But only the next year when I got better and stronger and more focused on figuring out what had happened did I begin to realize that there had been no transparency. And that really upset me because I have a strong sense of thinking justice is really important. And I also thought, if I can't find out what happened to me as a nurse and nursing professor and so forth, what is the average person? What can they do?
Well, you raise a very interesting question because it's my understanding that most hospitals around the country now have some expectations, ethical expectations, that if there is a mistake or harm, that health professionals are supposed to provide full disclosure. They're supposed to apologize and accept responsibility if there are medical mistakes, explain what happened and why, and then commit to preventing such mistakes from happening to anybody else. Apparently, none of that happened in your case.
No, I don't think that tends to happen now, and it's been, almost 9 years since my debacle. Let me backtrack a little bit. One of the courses I taught every year was ethics, medical ethics, health, nursing practice ethics. And so I was aware of the concepts that are part of how hospitals run and how doctors work and how nurses take care of patients. And I even looked at the consent form and some of the policies from the hospital where I was a patient. If they'd followed their policies, things would have been better. But things are written so that you can escape the truth by going into this phrase or that word. And if you don't know what to ask, then I think the average person is in trouble. So I don't think hospitals, they're not ready to make a shift in the paradigm of how they handle medical errors. There are some systems, healthcare systems, that have done this, and I think eventually it'll be more common.
Ms. Crisp, you just mentioned informed consent, and I wonder if you could explain to us what is informed consent and how exactly does it get used or misused?
Well, informed consent has to be signed before you go into surgery. You're giving the doctor, the hospital, permission to operate and take care of you. And so it will put down what, if you're going in to have a cardiac procedure or an amputation or cosmetic surgery, whatever you're going in surgery to have, this consent is you're giving permission to the doctor and hospital to perform this for you. However, the consent, in my opinion, I didn't used to think this, is written more for the doctor than the patient. They have ways of saying, well, if any, you're agreeing that surrounding organs may be damaged in the course of this surgery. That's very common. But they don't say, we're not going to tell you if it does happen. They're not saying, you give us permission that we accidentally, perforate your bowel and you almost die. Well, you signed the consent that this might happen, but you expect them to tell you if that's what happens. So informed consent, it's important to have some sort of consent for treatment. I mean, I work with patients and they have to sign a consent to treat before they are admitted, but it's not as wholly and holistic a document as some people think.
As a nurse who's actually taught ethics, and I'm sure have thought a lot about informed consent, you almost assuredly have had to grapple with some of the concerns that patients have because they're often presented with this document just before they're put under anesthesia. It's written in medical language or legal language, and it's like, well, if I don't sign it, they're not going to do this procedure. So I kind of have to sign it, even though you may not completely understand everything that's going to be done and what the risks are.
That's right. Well, and I think the main reason people sign it readily is because they just think the doctor's going to do what the doctor should do, and they wouldn't be asked to sign something that wasn't appropriate. They just take it for granted that it's part of the process. They have to trust, and think about it. If you're getting ready to go under the knife, you have to have some kind of trust in the doctor and the surgeon and the procedure, or it'd be really hard to go through that. I will tell you that after this situation with me happened, I had surgery the next year on my hand, so I was awake during the surgery. The nurse brought me the informed consent in the bay where I was waiting, and I made a change in it that nobody, that I wasn't agreeing that anyone could observe or participate other than my surgeon and his team. I don't think anyone had ever done that before, and I asked her to make sure that the surgeon saw this, and I knew him. I had known him in his office. So I go in, they take me into the surgery. I'm awake and alert. And he's got this young man there who's come in to see if he wants to be a hand surgeon. He's going to watch my surgery. And the surgeon had not looked at the consent, had not seen it. Now, that was not a surprise to me, but I think the point is that even if you're proactive enough to look at this document and think about it and and change it and initial the change doesn't mean the doctor's going to see that you've done that. There are some nurses that won't oversee an informed consent because they feel like it's the doctor's consent and it's the doctor who should be talking with the patient.
Donna Helen Crisp, your situation points out something that is far too common, probably not just in the United States, but all around the world, and that is medical mistakes. How common are they, and how big a problem is this for the medical profession as a whole?
Well, I want to say first that I used mistake and error interchangeably during the first few years I was working on my book, and then I came to realize that the best term was error, which is defined as the failure of something you've planned to do to be completed as you intended it, or you're using the wrong plan to achieve your goal. It is the third leading cause of death in this country, which was shocking to me. Hundreds of thousands of people die because of these errors, and many, many more like me don't die, but they have complications and they suffer as a result of some of the things that happen to them that they're never told about, or that many people assume that what went wrong, well, at least I didn't die. Things happen. I'm sure they did the best they could, but they have to figure this out on their own if they're interested. So it is a huge problem, and a major reason I wrote the book, Joe, was to help people have more consciousness about this situation, not to scare people, but to let them know that if you go in a hospital, it's better if you know the risks so that you can mitigate those that you can. And knowing that behind heart disease and cancer, that medical errors is the third leading cause of death, I think everyone should know that. Then I think the hospitals would be more likely to change faster. They rely on ignorance to some extent at this time.
Well, as you've pointed out, it is a huge problem. It's so big that it's hard to get a handle on it. Where do you think we should start?
We, the consumer?
Yes.
Because I think about this in terms of the consumer and the hospitals. I think the first place to start for us, consumers, which include doctors, they're consumers when they're sick, is to understand the reality, the threats to safety, and the fact that medical errors happen so frequently. Even if we can't ultimately do anything about that right now, knowing that that's a problem is a huge leap forward in public awareness. It is a health crisis, and the more people talk about it and understand it, I think the faster things will shift. I will tell you this, I have talked to many people over the last, actually 9 years. Many of these people don't know I'm a nurse, and they certainly don't necessarily know what happened to me, but I hear stories all the time from people who things went wrong for them or people they know and love. It's very common. It's just that a lot of people don't realize that it's everywhere. They think they're the main, this happened to them. They don't realize how common it is. So I think awareness is very important. And then on a smaller scale, I think we need to be proactive with asking questions and critical thinking. Don't be afraid to offend the doctor. I recently heard a story, I can't remember the details, just a week ago, and something didn't go the way it should have because the patient, she didn't want to offend her doctor. There was some question about the kind of treatment that had been recommended post-surgery for cancer, and she just didn't want to offend the doctor, so she didn't ask. So we need to ask questions.
One of the things that always has fascinated me is that we have a National Institutes of Health, and there they have, like the National Cancer Institute and the National Heart, Lung, and Blood Institute and allergy and rheumatism, all kinds of institutes, but nothing for medical errors. It's like if it's the leading cause of death, number 3, and some people suggest it may be even higher, we don't actually devote very many resources to it. And on most death certificates, they don't write, oh, this patient died because of a medical error. So we don't even have good statistics.
Well, I think that's very significant what you just pointed out, Joe. I didn't understand how death certificates are coded until the last month of the editing of my book. So I was able to put it in the prologue. When death certificates are filled out by doctors or funeral directors or other people, they are relegated to using only the International Classification Diagnostic Codes, ICD codes, for cause of death. And there is no ICD code for human or system error. So, frankly and cynically, this serves hospitals well who don't want to change. And people don't want to believe that hospitals have a strong corporate financial interest in people not knowing about these errors, but they do. They do. And until we can collect the information, I'm not sure how we'll do that. But if we want to, we'll figure it out. Until we can do that, it's going to be hard to get change to occur. We need it to change right now. Millions of people are going to die before this is figured out. If it's upwards of 500,000 a year, I mean, who knows how many it is, but it's a lot. I think it's an urgent situation.
You've been listening to Donna Helen Crisp, author of Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth. She had experience in social work, law, and music before she earned 2 nursing degrees. She's worked as a nursing clinician, administrator, supervisor, consultant, researcher, and teacher. Donna Helen Crisp is an assistant professor at the School of Nursing at the University of North Carolina at Chapel Hill.
Terry, transparency is so important in this entire process, but I suspect that a lot of health professionals worry about lawsuits. If they tell a family or a patient, "Ooh, we screwed up," well, they may call a lawyer. But what does the data suggest?
Well, the data that exist, and this is only somewhat studied, as we've been saying, suggest that disclosure and transparency actually reduce the risk of lawsuits. Now, a healthcare system may have to offer patients or a family some settlement, some recompense for having made a mistake. But if they do, they may be able to avoid a costly lawsuit.
Well, after the break, we'll learn about the obstacles to transparency.
Maybe healthcare should take a page from the airlines in learning to minimize critical errors.
Most hospitals now have departments of risk management. What do they do? Are they protecting patients or doctors?
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. The number is 800-345-7339. The website is uttercream.com.
If you'd like to purchase a copy of today's show, that would be on CD, or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show, number 1074. The number again, 800-732-2334. Find it online at peoplespharmacy.com.
We're talking about medical mistakes today on the People's Pharmacy. They're far more common than most people realize. Do patients have a right to know when an error has occurred?
Our guest is Donna Helen Crisp, author of Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth. She had experience in social work, law, and music before she earned 2 nursing degrees. She's worked as a nursing clinician, administrator, supervisor, consultant, researcher, and teacher. Donna Helen Crisp is an assistant professor at the School of Nursing of the University of North Carolina at Chapel Hill.
Donna Helen Crisp, it was very hard for your health professionals, the surgeon, for example, to tell you what went wrong in your case. But we hear over and over again that transparency at the hospital level, at the individual physician level, is not common. Why do you think doctors have such a hard time being transparent and taking responsibility for mistakes? Are they afraid of litigation? That's what we frequently hear.
Well, I think some people would like others to believe that's the main reason. I think it starts in medical school when, and this is slowly changing from what I understand, I think when people go to medical school, the traditional educational format is to, in some way, objectify patients so that you can study the left elbow or the right ventricle or whatever. And it's important to have emotional distance from your patient, but I think we have pursued that to the extent that we lose the connection of humanity between provider and the caregiver and the patient. And I think that doesn't serve anybody well. So people go through medical school, they learn, the bones, the organs, the systems, and they don't take the humanity of the patient with them into the office or the operating room. Second, hospitals, it's really a hierarchy from the way I see it. Doctors do not work for hospitals. Nurses do. That's an important distinction. Hospitalists, that would be an exception. They're hired by the hospital to be the doctor for the patients. Some insurance companies won't even cover these patients unless the hospital agrees to have hospitalists in there. But the hospital dictates policy and procedure and protocols when things go wrong. And I think my surgeon might have told me more if the hospital would have let him. But you're right, apologizing for something, a lot of people connect that to fear of, oh my gosh, they're going to sue me. In fact, there is research that shows there's less likelihood of a lawsuit if the doctor just comes clean. Gee, I'm really sorry this happened, and let me tell you what exactly took place and what we did about it. If they had done that for me, I would not have written the book that I wrote. I might have written a book, but it would not have been this book. My whole reason for writing the book was so that I could find out the truth and help other people realize what I didn't when I went into that hospital.
We've been talking about doctors and their transparency or lack of transparency. What about nurses? Do they have an obligation to come forward when they know there's been a problem? And if so, why don't they do it more often?
Well, they do have an obligation. We're taught in nursing school that our first and highest role is to be our patient's advocate. And that is very important. But I said a while ago, nurses are employees of the hospital. That is significant to keep in mind. Nurses know what goes on in terms of surgeries and so forth. The nurse that took care of me the night that I went into all that pain and I was supposed to go home the next day, she later told me she thought that I probably had a perforated bowel.
So
nurses know.
She had the experience to really assess what was actually going on, as the residents did not.
And I don't know, she was a night nurse, and I don't know what she did or did not ask or disclose to other people. In my ethics course, this topic came up frequently, and I'd get angry every week when I'd hear these stories. They're all true stories. My course was made up of stories that we brought to the conference each week from our own clinical practices. Nurses can do so much more than they do now, I think, without unduly threatening their livelihood. They can speak up. They can be passionate about pursuing the very best for each patient. And that's true a lot of the time, but not all the time. Doctors and nurses, I think this is happening more and more, they need to be trained together in medical and nursing school to learn how to communicate better because they're going to be collaborating. And I don't think you're going to find a smart doctor anywhere in a hospital system that doesn't honor and value what nurses know and tell him or her.
Well, it's interesting. We often hear the medical world compared to the airline world. And many, many years ago, there was a terrible tragedy because the co-pilot, although he was trying to tell the pilot that there was a problem ahead, that they needed to stop and not roll out on the runway, the pilot ignored him, and he felt too intimidated to actually jump in and say, stop now. And so as a result, there was a terrible accident and many people died. Nowadays, in the airline industry, we're told that, if a flight attendant says, I smell something, I don't like it, the pilot will immediately respond. And this idea that if there is a warning, everybody is on the same team, it hasn't quite penetrated into the hospital setting yet. That there is still a distinction between the hierarchy of the physician, especially the surgeon, and the nurse. Do you see that changing, and how can we make it move a little faster?
Well, I do think it's changing. I don't work in medical surgical units where I have a better idea of how quickly or slowly that is changing. I know that if you're the pilot of a plane and you screw up, you're going to die. And that's not true of a surgeon in an operating room. They're not going to die. And so I think there's a different urgency with flying than there is with going into an operating room. I think really good practitioners want to know the truth. They want patients to be skeptical and ask them questions. But I think hospitals, to a large extent to this point, have lacked the moral courage to name this issue for what it is and develop programs and trainings for transparency. What do you do when something goes wrong? Right now, I think often doctors have to let the risk management department know before anyone else. They can't even speak to their patient until they've notified risk management, and they have to wait for risk management to tell them what to do. I think there are a lot of changes that could be made right now if people had the courage to do it. And it should start at the top, but it may very well have to start at the bottom with you and me and all of us who use health care.
Ms. Chris, what is risk management?
Oh, I love that question. Risk management is a term for every hospital has risk managers or a department of risk management. You want to know what goes wrong, what might go wrong, what could go wrong, how much risk is it, should we do this or that, well, what's involved, because this has to do with money and marketing, and it does have to do with patient safety, although not as much as I think it should. So it's wanting to know ahead of time, well, if you go into this procedure, what are the risks? What are the risks for washing the floors at 3 a.m., and so forth.
And when something does go wrong, you said, well, the surgeon has to check with risk management first. So what is it they're doing?
Well, the risk manager is going to determine, I'm very cynical about this, Joe. They're going to determine what you can or cannot tell that patient. They're going to figure out a rationale for what they won't say, as well as what they will say. In my case, they said nothing, which I still find amazing.
I'd like to ask about how we could avoid a situation like yours. Are there any steps that patients can take going into an operation, for example? Obviously, we've talked about the informed consent and how you actually do need to know a lot more about the potential risks of surgery before you start. Do you need to have an advocate there with you? What else could be helpful?
Well, I think you need an advocate. I had someone with me. She didn't know much about hospitals or these kinds of issues. So, she was there to take me and bring me home. I think if I had to go back for surgery, which I actually have had to do, I had to have a huge repair surgery 14 months after all this happened. I had someone with me the whole time, all week, and she was a nurse. So I think if you have someone with you who is proactive, for example, every time someone comes in to give you a medicine, what is that? What's the dosage? What's it for? And write it down. Because there's a lot of research that shows medication errors continue to be very common. At one point, about 10 years ago, a huge study showed that there was about one medication error per patient day in this country. So I think being more aware and having someone with you is very important. I will tell you also that when I went for this surgery the next year, I went to pre-op, and it turned out the anesthesiologist who taught other nursing students to become nurse anesthetists was doing my pre-op appointment, and he got furious at me for changing the informed consent so that nobody would be in there to practice on me or observe me. He got furious. In fact, he told me I didn't have the right to do that. I had sent the nurse that was in there with me before he came in to risk management to make sure that I had the right to do that. And she came back while he was in there, and she said, yes, sir, she has the right to make those changes. He was not happy. But so I did learn something from, the year before.
Donna Helen Crisp, how are you doing today? And how did you get through what has been a very long journey?
Well, I'm doing fine. I have some consequences that still affect me from what happened to me 9 years ago, but I don't think about them very much, and I work. I'm still writing, and I'm still working as a nurse. I think that as soon as I got back, I came out of the ICU and went to the next phase of my hospitalization. I was still actually hallucinating, but I knew that I was, and it was much less than I had been 2 days before. I just sort of surrendered into the moment. There was nothing I could do. I couldn't leave. I already knew that I couldn't move. And I was used to this kind of mindful awareness of just staying in that moment. If I went into the past, it was just too painful. Oh, my God, why did I come here? Why did I do this? Why did I do that? If I went into the future, I couldn't even bear to think about that. I had no idea how I was going to survive as it was. So I think that I had long ago learned to take things as they come. I think I'm very resilient. I know that the rest of my life is ahead of me. I don't want to ruin it with, being too upset too long about things that have happened in the past. So I am doing well and hope to continue to do well.
And what would you like listeners to take away from your book, Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth?
Well, it's a very personal book. It's an intimate memoir. I've heard from a number of people who have read it. People who know me found it hard to read because they know me. People who didn't know me thought it was very compelling, and mainly that they had no idea about these subjects of which I wrote. I had one friend a few years after I was in the hospital for a month who was supposed to have a surgery and decided not to have it. She changed her lifestyle with diet and avoided the surgery, and wouldn't you know, 5 years later, she found out she didn't need that surgery after all. But if she had had surgery, she wasn't going to go into a teaching hospital. And I didn't tell her not to, but that was... So people have had different thoughts and feelings from reading the book, but I think it's done what I've wanted it to, which is to raise consciousness.
What are your hopes for the future of medicine and hospitalizations in this country, and how would you like to see patients change as a result of your experience?
Well, let's take medical education in hospitals. I want there to be transparency. I want people to be treated as human beings. I want people to own up to what happens, positive or negative. I want patients to be more aware, knowledgeable, and proactive. The old days of trusting your doctor to do what's best for you are over. When I grew up, our family doctor was worthy of that kind of trust. But that's not true anymore, where you go to see someone and they're not supposed to spend more than 7 or 8 minutes with you. So I think more consciousness raising about what actually goes on, how we can change, and transparency, no matter how hard it is, I just think we have to have it.
Donna Helen Crisp, thank you so much for talking with us on the People's Pharmacy today.
Thank you.
You've been listening to Donna Helen Crisp, author of Anatomy of Medical Errors, The Patient in Room 2, a nurse's story of surviving preventable medical errors and discovering the truth.
Before becoming a nurse, Donna Helen Crisp was employed in social work, music, and the law. She's an assistant professor at the School of Nursing of the University of North Carolina at Chapel Hill. The book is her memoir of discovering the multiple medical errors committed when she was a patient and somehow managed to survive. It has lessons we can all use before we become patients. She spoke with us from the studios of WCQS in Asheville, North Carolina.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1074. That number, 800-732-2334, or find it at our website, peoplespharmacy.com.
When you visit our site, you can check out information on medical errors, prescription drugs, herbal medicines, and home remedies. Share your thoughts on today's show. We'd love to hear about your story, whether you're a physician, a nurse, or a patient.
At peoplespharmacy.com, you could also sign up for our free online newsletter or the free podcast of the show. Listen at your own convenience or share it with a friend. It's all there at peoplespharmacy.com.
You can also become a friend of the People's Pharmacy on Facebook. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.